Dr. Polonawida and colleagues. Today our group will be discussing the case of Mr. CM. He is a 37-year-old male who has presented with recurrent oral thrush and periodic sore tongue. His chief complaint is that it feels like an extra flora in his mouth. Helen will introduce Mr. Child's dental and medical history. Lucky will go through the extra and intraoral examination and OPG review. Gundeep will list the differential diagnoses that we have decided upon. Amy will go through the special investigations, and Justin will finish with the management plan for Mr. CM. We have been provided with multiple clinical photographs which show obvious lesions on the lips, buccal mucosa, and tongue. I will now pass on to Helen, who will discuss Charles' dental medical history.
Dental history. In the case of Mr. CM, his patient history presentation shows ulceration on the tongue which had an adolescent onset. He reports no family history of such presentation. The pain is described as constant, sharp and uncomfortable that is diffused in the mouth but particularly worse in the tongue area. The frequency is every 3 months with the pattern changing each time. Pain is triggered and aggravated by spicy or acidic foods and chlorhexidine mouthwash and alleviated by Neostat drops. There's no trauma associated with this presentation. Medical history. So Mr. CM is taking a range of medications and we'll look at each of them individually. Neostat oral drops is an antifungal medication used to treat candida infections of the oral cavity. He is also taking lithium, which is a mood stabilizer for treatment of mania, bipolar, prophylaxis of recurrent depressive disorder, and schizoaffective illnesses. Risperidone is an atypical antipsychotic, and such newer medications has a reduced risk of developing tardive dyskinesia. This is used for treatment of schizophrenia and bipolar disorder symptoms. Procyclidine reduces effects of chemical imbalances as a result of disease, drug therapy, or other causes, thereby treating stiffness, tremors, spasms, and poor muscle control. Citalopram is an antidepressant for depression treatment, and lorazepam is a form of benzodiazepam, so it is used for anxiety disorder management. For his asthma treatment, Mr. CM takes Ventolin inhaler, which is a short-acting beta-2 adrenal receptor stimulant for relief of bronchospasms. In addition, Flixotide inhaler is also taken, which contains glucocorticoid. This is an asthma prophylaxis in adults with side effects of throat irritation and oropharyngeal candidiasis. The Oxys inhaler is a long-acting beta-2 agonist used as an adjunct to corticosteroids in long-term treatment of reversible airway obstructions as in asthma. Now we will turn to Mr. CM's general medical history. So no abnormalities were detected, leaving him as in a generally healthy state with regards to physical systemic diseases. However, his mental health is a bit of a concern. From the medications prescribed, it may be inferred that the patient has psychiatric conditions. Dentally related issues with regards to these drugs include uncontrolled facial movement, as in tardive dyskinesia, jaw grinding, impaired pain perception, and acute dystonia. His lifestyle habit of smoking more than 20 cigarettes per day is also a concern, as this may result in oral lesions such as smoker's keratosis, and in addition, this is also a risk factor of oral cancer. Overall, the most common side effect of his drug and chemical intake is xerostomia, and this not only causes physical discomfort to the patient but may also present as difficulties in swallowing, speech, and other functions of the oral cavity. It presents him at a higher risk of periodontal disease and dental caries progression, as well as candidal infection.
Thank you, Helen. Extraoral and intraoral exam is where we assess the soft tissues of Mr. CM, both intraorally and extraorally. Areas should be assessed systematically, starting with the extraoral and moving intraorally. Areas should be assessed visually and palpated where possible to examine for tenderness, pain, and any abnormalities such as discoloration or swellings. Starting with the extraoral exam, we will begin with the general appearance. Mr. CM has no obvious weight loss, no jaundice, no anemia, no cyanosis, no finger clubbing, no ankle edema, and no skin lesions. So to summarize the general appearance, we can postulate that Mr. CM's health is good, with a possible stable liver, cardiac and respiratory function. We have stated our indication of the general appearance in more detail in the slideshow, which you can see in the table. It is important for us to analyze these indications as it may dictate our differential diagnosis, special test, and our management plan. As we continue with the extraoral examination, we will again have broken this down into the findings and into possible indications in the table from which is on the slide. There was no visible swelling indicated, no acute or chronic inflammation from any trauma, chemicals, or diseases. The nose is also NAD, which indicates that the septum is possibly in line with the fulcrum of the nose, and that there is no disfigurement present, and the nasal function is normal. The lymph nodes, when visually assessed and palpated, was NAD. Therefore, no tenderness to palpation or hardness felt. This indicates no infection present in the head and neck region. The lips were NAD, which indicates no pathology like swelling of the lips or any ulcerations, and that the vermilion zone is a plump red color. Now to the intraoral exam. Although we were unable to assess the patient ourselves, we've been given clinical photos which we've interpreted and investigated and which have illustrated some of the intraoral soft tissues. This is a photo of the right-hand side dorsal surface of the tongue, as it is protruded out of the patient's mouth. There is an irregular shaped white lesion spreading across the lateral border of the right-hand side of the patient's tongue. The overall dimensions of the lesions appear to be 3 to 4 millimeters, and it does not appear elevated. This could possibly be oral candidiasis and leukoplakia. There also appears to be a brown melanotic macule just inferior to the patient's right-hand side corner of the mouth, and its borders are well circumscribed. The overall dimensions of the lesion appear to be 3 to 4 millimeters, and it does not appear elevated. This is a photo of the patient's mouth upon opening, with the left-hand side cheek retracted. The patient's posterior dorsal surface of the tongue is present, although hard to assess due to lack of exposure. The patient's left-hand side pterygomandibular raphe is clear and evident. There is a white striated lesion scattered along the left-hand side buccal mucosa, and its border margins are irregular. The overall dimensions appear to be 2 to 3 centimeters, and the lesion does not appear elevated. This could possibly be oral lichen planus, oral candidiasis, leukoplakia, or light reflecting of accumulated saliva. This is a photo of the patient's mouth upon opening. The patient's dorsal surface of the tongue is present, albeit hard to assess due to lack of exposure. The patient's lips are clear and evident, and no visible pathology or swelling in the vermilion zone or border. Lips and corners of the mouth appear slightly cracked, possibly due to dehydration. One area of concern is the right-hand side corner of the mouth, as it appears slightly elevated, although no signs of redness surrounding the right-hand side corner of the mouth. This could possibly be angular colitis. This is a photo of the patient's mouth upon opening, with the right-hand side cheek retracted. There is a white diffuse lesion which is surrounded by erythematous base with irregular borders, which also appear not well circumscribed. The overall dimensions appear to be 2 to 3 centimeters and does appear slightly elevated. This could possibly be major RAS or erythroleukoplakia. There is also this red line crossing the right-hand side corner of the mouth and extends into the buccal mucosa. This could have been formed due to dehydration or a sign of inflammation, which could be angular colitis. Now, lastly, we've been given an OPG, which we've interpreted to aid us in creating a differential diagnosis for our patient. The right-hand side condyle appears to be the articular eminence and in the articular fossa, although the left-hand side condyle appears on the articular eminence and not in the fossa. There is a radial lucency covering the angle of the mandible on both the right and left-hand side, which appears to be the oropharynx, and there's a radiolucent line which covers the ramus of both the right and left side, and going inferior, the hard palate, and crossing to the left-hand side ramus. This is the glossopharyngeal airspace. Teeth present are documented on the slideshow, but areas of concern include root canal treatment on the 14132344. There appears to be a metallic and tooth color restoration on the 1614132327363534 and 33. The alveolar height of the maxillary teeth does not appear to be within normal limits, especially in quadrant 2. This is identical for the mandibular teeth, and the alveolar ridge appears irregular in quadrant 4. Lastly, there is an alveolar socket post-extraction present in quadrant 4. Now I'll pass on to Gundeep, who will discuss the differential diagnosis from a history taking and clinical findings.
Oral ulceration is discontinuity of an epithelial surface induced by traumatic, inflammatory, or neoplastic processes. We have considered oral ulceration as a potential presentation due to the appearance of the buccal mucosa and by taking into account the patient history. Due to Mr. CM being on a variety of medications, they could be drug-induced lesions. Alternatively, it could be caused by trauma or tick biting. As previously mentioned, the pain is triggered by spicy and acidic foods, as well as chlorhexidine mouthwash, which may be associated with oral ulcers. These ulcers may be caused by a number of conditions, including leukoplakia, oral cancer, oral lichen planus, and oral candidiasis. Traumatic ulcers often arise at sites such as on the lips and the buccal mucosa. Typically, these ulcers are tender with a yellowish-gray floor of fibrous slough and margins which are red in color. Depending on the cause and the time since trauma occurred, there could be variation in the inflammation, swelling, and erythema present. Oral ulceration could be caused by recurrent aphthous stomatitis. Ulcers associated with RAS are painful mucosal lesions which commonly present in the oral cavity. These lesions present as recurrent, multiple, small, round or ovoid ulcers with circumscribed margins, having yellow or gray floors surrounded by erythematous halos. They are often first present in childhood or adolescence. However, most patients are non-smokers. In the case of Mr. CM, the onset of the presentation was in adolescence, thus we have considered ulceration due to RAS. Recurrent bouts of solitary or multiple shallow painful ulcers are characteristics of RAS. They occur at intervals of a few months to few days in patients who otherwise present well. The patient may also present with ulceration of the tongue. The tongue could be the affected site of various types of stomatitis. These could include herpes simplex or more frequently lichen planus. Solitary ulcers could also be present on the tongue, particularly carcinoma. It may be difficult to see if they are located far back. The lateral borders of the tongue are affected, but carcinoma of the dorsum of the tongue is rare. The differential diagnosis of candidiasis shouldn't be ruled out, as the presenting complaint is recurrent oral thrush as well as a whitish appearance, which is able to be seen in the images, especially on the dorsum of the tongue and to an extent on the buccal mucosa. Candidiasis is a fungal infection which occurs due to an overgrowth of the yeast Candida. In this sense, pseudomembranous candidiasis could be the presentation. Pseudomembranous candidiasis is characterized by the presence of creamy white lesions on the oral mucosa. It is able to be diagnosed if by gentle scraping these plaques are able to be removed and which leave behind an erythematous surface. Another form of infection associated with candida could be erythematous candidiasis. This infection commonly occurs on the dorsal surface of the tongue or the palate as reddened lesions. However, it is able to occur on the buccal mucosa. It is consistently painful. We have also considered candidal leukoplakia, chronic hypoplastic candidiasis, as a potential differential diagnosis. Smoking is a predisposing factor. Additionally, it commonly affects the dorsum of the tongue and the postcommissural buccal mucosa and presents as a rough irregular surface, which can potentially be seen on the right-hand side buccal mucosa. Some of these characteristics are consistent with Mr. CM. We have also considered angular colitis as a differential diagnosis due to the appearance around the corners of the mouth. Angular colitis could be another presentation associated with candida. It is an inflammatory condition which affects one or both angles of the mouth. Common presentation of this condition includes erythema, painful cracking, scaling, bleeding, and ulceration. Some of these characteristics can be seen in the image. Dry, cracked appearance at the corners of the mouth and possibly ulceration is able to be seen on the right-hand side. The white patches seen on the buccal mucosa could be due to frictional keratosis and cheek biting, which may be due to irritants such as a sharp tooth, for example. Clinically, on initial presentations, the patches appear pale and translucent, however later become dense and white and sometimes with a rough surface. An area of the buccal mucosa that is associated with habitual cheek biting may appear patchily red and white with a rough surface, which can somewhat be seen on the right-hand side buccal mucosa. Hyperkeratotic lesions are often secondary to chronic irritation, this including biting and/or tobacco use. As Mr. CM is a smoker, the white presentation on the buccal mucosa could be because of hyperkeratosis. Due to Mr. CM's medication use and the appearance of the buccal mucosa, the lesion in question could be lichen planus. Lichen planus is a common chronic inflammatory condition associated with the skin and mucous membranes. Striae, atrophic areas, erosions, and plaques are among the clinical features of lichen planus. Striae are the most common and often form snowy white, lacy patterns, which are sharply defined. Although there are white appearances on the buccal mucosa, it does not appear to be as characteristic of lichen planus. However, it should be taken into consideration and other tests performed. Lesions associated with lichen planus may also appear as tender, red inflamed lesions and open sores and may be associated with pain or a burning sensation. However, the white lacy patches of lichen planus may not be associated with pain on the buccal mucosa, but if involving the tongue they may be painful. Furthermore, sensitivity to hot or spicy foods could be experienced with lichen planus. This is the case with Mr. CM. Additionally, we have also considered leukoplakia. Leukoplakia is a condition that affects the mucous membranes of the mouth and typically presents as patches on the tongue and buccal mucosa. Leukoplakia may be due to irritation such as rough teeth, smoking or other tobacco use. Patches associated with the condition usually appear white or gray, uneven in shape, fuzzy, slightly raised with a hard surface, cannot be scraped off, and often present with pain when contacting acidic or spicy foods. Burning mouth syndrome could affect an individual as chronic burning pain in the mouth. Often the cause of burning mouth syndrome cannot be determined. The pain is described as burning, scalding, or tingling. Often the primary site affected is the tongue. However, the pain could be in the lips, palate, or throughout the mouth. The location is similar to that described for Mr. CM, as well as the pain description as constant and sharp, which corresponds with the burning description. Also, hot or spicy foods, tobacco, mouthwashes which contain alcohol, and other products high in acid are considered as irritants with this condition. Other conditions such as chronic anxiety and depression are often associated with burning mouth syndrome. Mr. CM is on a variety of medications for anxiety and depression. Dry mouth due to medications is also associated with burning mouth syndrome. Thus, we have considered this condition as a differential diagnosis.
Just a disclaimer, I'm not Amy Thompson, I'm Lucky Rebel, but I'll be speaking on Amy's behalf. So, special tests. Now that we have a differential diagnosis, it is important to perform special tests in order to rule out or confirm each of the conditions Mr. CM may have. Oral ulceration. Firstly, our patient may have oral ulcerations. Diagnosis of these ulcerations usually include three main investigations: a physical examination, blood tests, and a skin biopsy. The ulceration should be monitored for healing and changes of the patient's next appointments. If an obvious cause is not found upon examination, blood tests should be done to rule out other causing factors such as infection, as well as check blood cell count and iron levels. If after 3 weeks there is still no improvement to the lesion, a biopsy should be taken. Candidiasis. Candidiasis is another potential differential diagnosis for Mr. CM. Confirming the presence of candidiasis can be often done through a thorough examination. One would expect to find the mucous membrane to be developed a white coating and an uneven distribution within the oral cavity. Lesions may also appear to be speckled white or red, and it will be important to try to rub off the lesion to rule out pseudomembranous candidiasis. A smear biopsy may also be performed for clinical examination. Typically, one would expect to see increased neutrophils, inflammatory cells in the chronic candidiasis, marked hyperkeratosis, and a crust-like formation. For angular colitis, in most clinical cases, diagnosing angular colitis can be done via clinical examination due to its distinct characteristics. However, microbiological investigations such as swabbing the lesions can be useful. This will rule out other conditions which may mimic, such as herpes labialis. Frictional keratosis and cheek biting. Investigation into possible frictional keratosis and cheek biting is, like many other conditions, done through the clinical examination. As these lesions often potentially can become malignant, oral lesions and cancers, it is important to confirm the diagnosis. Optical visualization devices have been recently made to able to assist in clinical examinations. These devices use autofluorescence and reflective tints, diffused white light, and an acid rinse to help differentiate between benign and malignant mucosal disorders. However, it should be noted that the clinical trials are still underway to determine the effectiveness and sensitivity of these devices within clinical practice. If the lesion presents atypical or is of concern, a biopsy should be such as a scalpel biopsy is indicated. Histologically, findings typically include hyperkeratinization of the surface epithelium, which may be smooth, corrugated, or ragged with keratin projections. Lichen planus. Diagnosis of lichen planus can in most cases be done clinically. A punch biopsy may also be aid in diagnosing the lesion, as well as rule out other conditions that appear clinically similar. Histologically, lichen planus typically presents with epidermal hyperplasia, hyperparakeratosis, and alterations of the basal layer of the epidermis. And a large infiltration of mainly T cells may also be seen at the epidermal junction. A blood test in these cases would also help to rule out other conditions such as hepatitis. Burning mouth syndrome. As explained by Gundeep, Mr. CM may also indicate burning mouth syndrome. Unfortunately, there is no one test that can confirm this diagnosis, but rather a series of tests to rule out other conditions. These include salivary, blood, allergy, and imaging tests as well as oral swabs and biopsies. Lastly, leukoplakia. The diagnosis of leukoplakia is also commonly done through clinical examination. However, in atypical cases or for confirmation, further testing can be carried out. A biopsy of the lesion will most commonly show hyperkeratosis and parakeratosis. Patients will display varying disease levels, inflammatory cells infiltrating the lamina propria, as well as varying levels of dysplasia, if any at all. There's also likely to be an increased nuclear to cytoplasm ratio, irregular epithelium stratification, increased number of abnormal mitotic figures, and nuclear and cellular pleomorphism. I will now pass you on to Justin, who will be discussing the management of our patient.
Thanks, Amy. The definitive diagnosis can only be made after the results of the special tests have arrived. Nevertheless, we present a treatment plan that will address all our differential diagnoses. Good communication is essential with the patient to obtain informed consent. Our treatment plan is divided into 5 phases: systemic, acute, disease control, definitive, and maintenance. Systemic phase. It is essential to have brief motivational interviews for smoking cessation. Furthermore, consultation with Mr. CM's GP to change his drug regimen to a less xerostomia-inducing ones also should be done. Acute phase. There is nothing to be done in this phase. Mr. CM's soreness will be addressed in the disease control phase. Disease control phase. If the diagnosis is recurrent or pseudomembranous candida, we will first review the initial diagnosis and otherwise continue antifungal regimen. This will be amphotericin 10 mg dosage sucked and then swallowed 4 times daily after food for 7 to 14 days. If it is burning mouth syndrome, a pain scale of 0 to 10 will be used to assess the patient's pain perception and in order to assess the pain levels after treatment. Psychological management such as relaxation techniques and stress-relieving exercises could help in distracting Mr. CM from his pain. Pharmacological management via antidepressants and antiepileptics such as clonazepam requires specialist referral. Oral ulceration. Ulcers usually heal within a week or 2 depending on their size. For symptomatic relief, topical anesthetics such as 2% lignocaine gel can be given. This can be with or without 0.05% chlorhexidine, which is to be used every 3 hours. In order to control the disease, we will prescribe betamethasone dipropionate 0.05% ointment, which is to be applied topically twice daily after meals. Angular cheilitis. Since angular cheilitis is caused mainly by Candida species, along with staphylococci and streptococci, antifungal treatment should continue. Persistence will require specialist management. Frictional hyperkeratosis. This is usually asymptomatic and so doesn't require any intervention. We just need to reassure the patient. Lichen planus. If the lesions are symptomatic, then prescribe betamethasone dipropionate 0.05% ointment, which is to be topically applied twice daily after meals. If lesions are persistent for more than 3 weeks, specialist referral is warranted. Leukoplakia. Generally, leukoplakia is asymptomatic and so doesn't require any intervention. The next phase will be definitive phase, and there is nothing to be done in this phase for Mr. CM. Moving on to the maintenance phase. Initially, we'll place the patient on a 3-month recall to review pain control and monitor the lesions. After pain levels have subsided and the lesions are healing, we will place the patient on a 6-month recall. In every recall visit, brief smoking cessation motivational interviews are to be provided. Now I will pass you on to Sun, who will conclude.
It is difficult to diagnose Mr. Charles given our limited information about him. From the clinical photograph that we have received, we have come up with possible diagnoses that could be present. We will need to await for the results of the special tests to attain the definitive diagnosis. From then, we would treat and formulate a treatment plan that best suits the diagnosis. In the systemic phase, we would like to discuss smoking cessation. The disease control phase consists of controlling the diagnosis depending on the results of the special test. Thank you for listening.